Welcome to the deep dive. This is where we take a stack of sources today, some fascinating medical excerpts, and really pull out the key pieces of information. Our goal, as always, is to help you get properly up to speed on a specific topic. And today, we're diving deep into Bell palsy. Okay, so let's unpack this. Imagine, suddenly one side of your face just weakens or becomes paralyzed. It must be incredibly unsettling. And get this, something like 60 to 75% of all facial paralysis cases, they're actually due to Bell palsy. That's
right. Well, that's a huge number, right? It makes you really ask, what is this condition?
Right. Simply put, Bell palsy is that sudden weakness or paralysis on one side of the face. The medical definition is idiopathic, peripheral facial paralysis, or paresis of acute onset. Now, idiopathic, that's the key word here. It basically means that for most people, we don't know the exact initial trigger. It often just appears suddenly. So it just sort of happens.
Out of the blue, that is perplexing. And definitely unsettling for anyone going through it. Who does it usually affect? Is it more common in certain people? Well, it affects men and women pretty equally. And you can get it at any age, although the chances do seem to go up as people get older. What's interesting, though, is the risk is higher in diabetics. That's likely due to something called angiopathy damage to small blood vessels. And also in pregnant women. We think that's probably related to fluid retention during pregnancy.
Ah, okay. That's really important context about those higher risk groups. And, digging into who gets it, I was struck by the family connection. About 6 to 8% of patients have a family history. So there seems to be some kind of hereditary component, too. It's not always just random. We said it often just appears, which is the unsettling part. But let's get into the science. What do we actually know about the mechanisms, what's going on inside the body?
So looking at the bigger picture, most of the evidence points towards a viral cause. We're often talking about common viruses like herpes simplex, cold sore virus, or herpes zoster, shingles, or even the Epstein-Barr virus. And it's worth noting, sometimes other cranial nerves might be involved too. So some researchers see it as part of a broader picture, like a polyneuropathy affecting multiple nerves.
Okay, so viruses are a leading theory. Are there other major factors involved?
Absolutely. Another significant factor is something called vascular ischemia. That's essentially reduced blood flow to the nerve. This ischemia, it can be maybe triggered by things like, say, exposure to cold or even intense emotional stress, or it could be secondary. So the primary issue causes capillaries to become more permeable, fluid leaks out, you get swelling edema, and that swelling physically compresses the nerve and its tiny blood vessels, the microcirculation.
That makes sense. The nerve literally gets squeezed. So this raises a question. We mentioned that hereditary link earlier. How does that predisposition fit into this picture of nerve compression?
Yeah, it's a really critical piece. You see, the facial nerve passes through a narrow bony tunnel in the skull called the fallopian canal. In some people, due to hereditary factors, this canal is just naturally narrower, and that anatomical difference makes their nerve much more vulnerable. Even a tiny bit of swelling, slight edema, can be enough to compress it early on. And yeah, like you said, about 10% of cases do report that family history.
Okay, so we've got viruses, blood flow issues, genetics. Have researchers noticed anything else contributing? Maybe something related to the immune system?
That's a great point. Yes, there have been observations involving T lymphocytes, which are key immune cells. Changes in these cells suggest there might be an autoimmune component. So the body's own immune system could potentially be mistakenly attacking the facial nerve. It just adds another layer of complexity, really, to understand where Bell palsy comes from.
Wow, okay. So it's clearly complex. Let's pivot then to what can actually be done. What are the typical ways to manage Bell palsy once it's diagnosed?
Right, treatment. Well, first off, general management is key. Reassuring the patient is incredibly important. It can be a frightening experience. If there's ear pain, which can happen, simple analgesics can help with that. And then, crucially, eye care. This is paramount. You need to protect the eye on the affected side from drying out and getting damaged, what we call exposure keratitis, because blinking might be incomplete. Physiotherapy or sometimes facial muscle massage is often recommended too. It provides some psychological support, and it encourages active movement when recovery starts.
And what about actual medical treatments, medications? Is there a main drug people use?
Yes. Steroids are generally considered the drug of choice, specifically prednisolone. Now, it's really important to say this. While they were widely used and often seen helpful, their effectiveness hasn't actually been proven beyond all doubt in every single carefully controlled study. So there's still some debate. The dosing, it really depends. It's typically based on weight, like 1 milligram per kilogram per day, usually for about 5 days to start. Then how you taper off depends on the situation. If the paralysis isn't complete, or if it's already improving, the dose is usually reduced over the next 5 days. But if the paralysis is complete and not improving, the full dose might continue for another 10 days, then tapered over 5 days, so maybe 20 days total. It needs careful medical supervision.
That's a key nuance, that it's not definitively proven in all studies, despite being the main treatment. What are the benefits doctors are hoping for when they prescribe steroids?
Well, what's fascinating is that steroids seem to be useful for preventing some of the potential long-term complications. Things like synkinesis. That's where you get unwanted facial movements, like your eye closing when you try to smile. And also crocodile tears, which is tearing up when you eat. Steroids might help prevent those, and they can also shorten the overall recovery time for the facial paralysis itself.
That's definitely compelling. Are there situations where steroids shouldn't be used? Contraindications?
Yes, definitely. There are important ones. Steroids aren't usually given during pregnancy, or if someone has diabetes, high blood pressure, a peptic ulcer, active tuberculosis, or glaucoma. It's also worth mentioning sometimes steroids are combined with an antiviral drug, like a cyclovir, especially if it's thought to be related to the shingles virus, herpes zoster oticus, or even sometimes just for Bell palsy itself.
Okay, so beyond steroids, what about other common medications people might ask about? Things like vitamins or antihistamines, are they effective?
That's a common question. But unfortunately, things like vasodilators, drugs to widen blood vessels, vitamins, mast cell inhibitors, antihistamines, none of these have really been found to be useful for Bell palsy. The evidence just isn't there.
Right, so it really narrows the focus medically. What about surgery? Are there surgical options?
Yes, surgical nerve decompression is an option, although it's generally less common now than it used to be. The idea is to physically relieve the pressure on the nerve fibers within that bony canal we talked about, the fallopian canal, and hopefully improve its blood supply, the microcirculation. Surgeons usually decompress specific parts of the nerve, like the vertical and tympanic segments. Some specialists even suggest a more extensive total decompression, which might involve different surgical approaches depending on where the compression is suspected. But again, it's less common nowadays.
That gives us a really good picture of the treatments. So let's wrap up this deep dive by looking at the outcome. What's the prognosis usually like for someone with Bell palsy?
Considering everything, the prognosis is actually remarkably good for most people. The really encouraging news is that 85 to 90% of patients recover fully.
Completely.
Wow, 85 to 90% full recovery. That is incredibly hopeful. But what about the other 10 to 15%, the exceptions?
Right, so about 10 to 15% don't recover completely. They might be left with some residual effects, some signs of nerve damage. Doctors sometimes call these stigmata of degeneration. And it's also true that if someone has Bell palsy more than once, recurrent facial palsy, the recovery might not be as complete with later episodes compared to the first time.
Okay. Are there any early signs that might suggest someone is heading towards that better full recovery outcome? Yes, definitely. What's really positive is that if the Bell palsy is incomplete to begin with, meaning there's still some facial movement, not total paralysis, the prognosis is excellent. About 95% achieve complete recovery in those cases. And another good sign is timing. If clinical recovery, visible improvement, starts within the first 3 weeks after it begins, that predicts a 75% chance of complete recovery. So early improvement is definitely key.
So quite a journey we've taken, from understanding what Bell palsy actually is to exploring this really tangled web of causes, viruses, genetics, maybe autoimmune factors. We've looked at treatments, from the vital eye care, the role of steroids, the lack of evidence for other drugs, and even surgery. And finally, ending on that generally positive note, the high recovery rate for most people. It's a condition that, it carries that idiopathic label meaning cause unknown, but there's clearly a lot going on beneath the surface, and thankfully a hopeful outlook for the majority.
Exactly. It really highlights how, even when we don't know the single starting point, medical science can still make huge strides in understanding the mechanisms and finding ways to manage conditions effectively. It often comes down to connecting different pieces of the puzzle, viral links, vascular issues, genetics. It reminds us that idiopathic doesn't mean unknowable or untreatable.
So what does all this mean for you, listening? Maybe reflect on how often we encounter conditions like this with these complex origins. It could be viral, hereditary, autoimmune, often a mix where finding one single smoking gun cause is tricky. What does digging into something like Bell palsy tell us about how medical mysteries are constantly being unraveled and about the power of just nuanced understanding? It really shows how these deep dives into specific sources can light up broader patterns in health and knowledge and maybe push us all to keep asking questions about how the body works.